because Dr. is an ENT by training. She practiced as an ENT for years before going into cosmetic surgery. The treatment of the patients was below the standard of care because they weren't candidates for surgery.
Nobody should be scarred from a surgery that's supposed to make them look better to that extent. No one should die from a surgery that's supposed to make them look better.
Oof. Did you catch that? A physician that performed surgery on patients that resulted in catastrophic outcomes ended up before the board for what happened in the course of her practice. Maybe you recognize the voice of our Deputy Director of Enforcement, Mindy Snyder, who at the time was serving as an Assistant Attorney General. Today we're walking through a case involving bad decision-making and cosmetic surgeries that led to dismal patient outcomes and further exploring the topic of minimal standards. If you have not yet listened to the previous episode where we explain the standard of care, I encourage you to go back and listen to it. It'll set the tone for the case we'll be discussing today. Now, as we get started, I want you to ask yourself, what happens when a doctor who practices outside of their area of expertise causes irreversible damage? Find out in today's episode. You're listening to MedBoard Pulse, a podcast by the State Medical Board of Ohio. I'm your host, Jerica Stewart, Chief of Communications. Let's talk, Ohio. Just in listening to this intro, I know you've got to be curious about the case we're diving into today. 3-day lipo trainings, botched surgeries, and multiple deaths sound like something from a Lifetime movie. But sadly, this case really happened here in Ohio and impacted the very real lives of patients and their loved ones. If you listened to our last episode, you learned that the standard of care is the level of care that a reasonably competent and skilled healthcare professional with a similar background and type of practice would have provided under the circumstances. This definition is intended to be flexible because just as scientific methodology and technology changes, so can what is expected from providers working in a particular field. I think we can all agree that no matter what specialty your provider practices, when faced with the worries and concerns about an illness or procedure, the last thing we want to worry about is the ability of your provider to be able to do what you are going to them for. Which leads me to our case today. We'll be examining a physician, we'll call her Dr. X, who was issued a citation based on allegations that she failed to conform to the minimal standards of care for surgery, inappropriately monitored oxygen saturation levels and blood levels, and inappropriately prescribed multiple anxiolytics, which is a drug class often used for the treatment of anxiety disorders. If that wasn't enough, later in the year, the board issued her a summary suspension, which immediately suspended her license due to clear and convincing evidence her continued practice presented a danger of immediate and serious harm to the public. Dr. X exercised her right to request a hearing and brought her case before the board. And that's where we'll pick up the rest of the story. Joining me today is enforcement attorney Tim Norris, who actually worked to develop this case and see it through to board discipline. Tim, thank you for being here today.
You're welcome. It's good to be here.
Can you please introduce yourself and explain your role at the medical board?
Yes, I am Tim Norris. I am an enforcement attorney with the State Medical Board of Ohio. My role is to aid the board in discovering whether complaints that are made to the board once investigated have uncovered violations of Ohio Revised Code, and then developing evidence to prove that. And that's the Ohio Revised Code as it pertains to discipline of Ohio licensed physicians and other allied practitioners. This includes obtaining documents in an investigation, deposing witnesses, drafting notices of opportunity for hearing, and making recommendations to the secretary and supervising member of the board, whether to close complaints, whether to offer settlement, or pursue other avenues of resolution of a substantiated complaint.
That's a lot. Yeah. Absolutely. So you are pretty heavily involved in cases that come to your desk, it's fair to say.
I have my hands in them once they come to me. They usually come to me from an investigator, especially in a case like this. So there will be a lot of work done beforehand, but I still have a lot to dig through and then a lot to do once I get it.
And in explaining that, one of the significant aspects of the case that we're looking at today is understanding how this doctor ventured outside of her area of competency. Most doctors complete a residency, which is basically hands-on training that newly licensed doctors complete after medical school to prepare them to practice medicine independently. What was the focus of Dr. X's residency program and other postgraduate training?
She completed a 1-year internship in general surgery before she began residency. Her residency was a 4-year residency program in otolaryngology.
What is otolaryngology? That's a fancy word.
An otolaryngologist is what lay people would call an ENT, an ear, nose, and throat doctor. Dr. X was trained as an ENT and had a decades-long career in ENT and head and neck surgery.
Okay. So primarily her training was in ear, nose, and throat, and she had a little bit of surgery experience and kind of in her background. How many patients were a part of this case?
The case all total was 5 patients.
So I think in our last case example, the sexual misconduct we did with Mindy, she mentioned that kind of situation. Is that common for a case to start being developed and the board to cite someone and then an additional patient comes forward in that time in between and there's basically a new allegation to look into?
It isn't common, but it does happen usually in situations where it's usually a standard of care case or a sexual misconduct case where a physician has practiced below minimal standards of care or has done something inappropriate with a patient and then continues practicing and continues making those same mistakes.
For this particular case, the board brought in a plastic surgeon as an expert witness. What is the purpose of an expert in a situation like this?
The expert witness reviews the patient record, which is everything a physician maintains in their treatment of a patient. The expert looks at that patient record and assesses the physician's care, treatment, diagnosis, everything they did in their care of that patient. The expert takes a look at and assesses whether that is conforming with minimal standard of care as it relates to similar practitioners. And also whether the expert determines whether the physician violated our board rules. In a case where we take action based on an expert's findings, the expert will eventually be called to a hearing and is subject to cross-examination either by the physician or the physician's attorney. So in this case, we obtained an expert in cosmetic surgery to review all 5 patients that we're talking about. And then that expert drafted opinions about all 5 of those patients individually.
And that's where we'll pick up the story after a short break.
Looking for a meaningful career? Join Team Ohio. It's more than just a job. The state of Ohio offers a wide range of career opportunities. To search for jobs with the state of Ohio, visit careers.ohio.gov. At Team Ohio, we take care of the team that cares for Ohioans. We offer a competitive salary and benefits package. To learn more, visit careers.ohio.gov and check out the state of Ohio on LinkedIn.
We've been talking to enforcement attorney Tim Norris about a surgeon who failed to meet the minimal standards of care for her patients. So as we get into the real meat of this case, we're going to start looking at patients individually. So can you tell me a little bit about what happened to patient 1?
Yes. So patient 1 was 61 years old at the time of Dr. X's treatment. When she came in, she weighed 172 pounds and had a BMI of 31. When we talk about weight and BMI, it's not to make any judgments about health. It's important that the doctor is conducting a risk assessment before any elective procedures. And higher BMIs increase risk of complications during surgery and also in the healing process. So it's not that someone who has a BMI isn't an appropriate candidate for a cosmetic procedure. It's just that there are additional safeguards that have to be gone through.
And I think I want to make sure we are clear in saying these were not surgeries to help fix a health condition or things that were like a needed medical emergency. These were elective surgeries, and these were specifically cosmetic surgeries that patients came looking to look better or to feel better.
That's what we're talking about. We're not talking about life-saving or even health improving procedures. We're talking about appearance. Patient 1 had that BMI score we were talking about. She also had abdominal scarring due to a previous hysterectomy. She had also been a smoker of at least half a pack a day for 20 years. Smoking history, again, just like BMI, we're not talking about smoking to judge a patient. It's important in the risk assessment. People who smoke, people who don't smoke, we're lay people, we don't necessarily know, but smoking causes problems in the healing process when it relates to procedures involving the skin, and it can create scarring problems. So patient 1 had all of those things going on. What she wanted was liposuction. Dr. X performed laser-assisted tumescent liposuction.
What is that?
That is, there's different types of liposuction. So liposuction is fat removal, and it's either through using a tool that basically injects a fluid that numbs the body while the machine also is pulling fat out. And laser assisted means that the laser is heating the skin up to soften that as it's happening. So with patient 1's risks, after this laser assisted liposuction was performed, about 2 weeks later, when she came back, Dr. X's employee took note of patient 1's appearance, and patient 1 had burns and skin necrosis on her abdomen.
What's that?
Unfortunately, what that means is that larger areas of her skin on her tummy area and on her flanks were charred black, and skin dyed as a result of the cosmetic surgery.
What happened after these notes were taken by someone in Dr. X's office?
Patient 1 ended up going through about a month's worth of subsequent treatment. She underwent debridement, which is cleaning of wounds, but in the case of necrosis, it's cleaning dead flesh out of the human body. And she suffered permanent scarring as a result.
Can you talk a little bit about patient 2 and what that patient experienced?
Yes. Patient 2 was 49 years old at the time of her treatment. She came in, she wanted facial rejuvenation, which is a facelift with extras. In this case, the facelift involved excising of the skin. She also wanted liposuction, laser skin tightening, and eyelid surgery. Patient 2 had a history of liver and kidney failure. Her father had died at a younger age of pulmonary embolism, and her mother died from stroke. She weighed 250 pounds pre-op and had a BMI of 43.82.
And so that's another one of those red flags, right?
Yes. And our rules require for patients with a certain score, she would be scored a 3, which means if any procedure would be done on her, it shouldn't be done in an office setting.
Ah, I see. So that's a part of his case as well. These are not procedures that are happening in a hospital. These are happening basically in a doctor's office, right?
Correct. And we're talking about very complicated procedures, and we're going to talk about patients under sedation. And the more complicated the patient, the more complicated the procedure, the riskier it gets. And the more practitioners are sometimes encouraged and sometimes obligated to move those procedures to a hospital or an ambulatory surgical center.
for the proper protections to be in place, basically.
Yes, they're going to have anesthesiologists on staff there monitoring the patients having surgeries. They're going to have nursing staff. They're going to have the proper beds to determine, to give people proper aftercare when they come out of surgery. Dr. X performed the facial rejuvenation with facelift, with skin excision, liposuction, laser skin tightening, and the eyelid surgery. The procedure lasted almost 4 hours, 3 hours and 49 minutes, I believe, during which time patient 2 was sedated using Valium, Percocet, Xanax, oxycodone, and other drugs, including Flexeril. Patient 2 was released to the next of kin post-op, but when she got home, she suffered cardiac arrest, and she died the same evening. She definitely should not have had this procedure in her current state done. She wasn't a safe candidate. And the sedation that was required to sedate someone with that BMI in an office setting it just created a dangerous situation.
I see. If we can you explain a little bit about what happened to patient 3?
Patient 3, when he presented to Dr. X, was an 85-year-old lifelong smoker.
No, we already said this is a problem.
Yes, and this 85-year-old patient, lifelong smoker, he was also suffering COPD. He wanted a facelift. This was an inappropriate procedure. Dr. X sedated the patient using multiple anxiolytics, which are, depressants. So the same as patient 2, you're given an unhealthy person a lot of central nervous system depressants, and in a setting that it's not necessarily safe to do so. During the procedure, the oximeter showed that the patient wasn't getting enough air. Dr. X continued the facelift procedure. The patient, when he awoke, he went to use the bathroom and he suffered cardiac arrest. And he died in hospital later that day.
I know that a lot of the details in this case came out in the hearing. And so as a board, we got to hear from Dr. X. What was her general response as, counsel and the state was really walking through each of these cases? What was her general response to, explain her behavior?
It was basically to try to nitpick each data point that should have told her that this candidate for this particular procedure, whichever procedure we're talking about, was not an appropriate candidate, or it was not an appropriate setting or not an appropriate time based on that candidate's health.
Her documentation in this process was horrible too, right? And there were different, I feel like I remember seeing there are different BMIs, different places, different weights in different places. Like she said, 85-year-old guy, he's healthy because he works on a farm. It's like, what?
And the problem was, and I don't know what the motivations are, but it's clear the patient wants the procedure. We're going to figure out a way to do the procedure.
Yeah.
Even though it's my job to tell the patient this procedure might kill you.
Can you please share some information about patient 4's case?
Yes. Patient 4 presented to Dr. X in 2014 for a facelift. At the time of the surgery, the patient was 69 years old. She had a history of COPD, which was problematic, and she was also being medicated for high blood pressure. Dr. X gave 2 types of anxiolytic, the diazepam and the Ambien, the 2 anti-nauseatics, and Percocet. During the procedure, before it ended, patient 4 suffered cardiac arrest. Dr. X and her staff performed CPR. She was transported to the hospital. She ended up dying about a week after the procedure.
This is a 3rd patient that is deceased. I'm curious about this cocktail of prescription drugs that she's prescribing for the surgeries. It does seem strange. Maybe I'm just unfamiliar with how physicians typically put someone to sleep, but.
So we're not supposed to be quite putting them to sleep. when I say we, I'm talking about office-based practitioners. Part of the problem is they're not supposed to be going into moderate to high sedation. And usually that means a use of one or a combination of two anxiolytics in an office setting instead of the full-on anesthesia you'd get in a hospital setting. The problem with that is when you are in an office setting with an at-risk patient, then using those anxiolytics, it might be sedating them more than you realize.
I see. So we're really talking about some deep understanding and knowledge of chemicals, of almost like this is pharmacology. And so this is complicated.
We have rules about what type of patients can be treated in that type of setting. But physicians also have a standard of care, and some of these patients probably shouldn't have been treated one way or the other.
There's that term again. We're back to the reason why we're here today, failing to meet a standard of care. I think we have just one patient left.
Patient 5 presented to Dr. X because she wanted liposuction. She had a history that included sickle cell disease. She had atrial fibrillation and a prior tubal ligation. Dr. X said that she did not know at the time of the sickle cell disease, but patient 5 did have a prescription for oxycodone, and Dr. X never asked her why she had that prescription, but that prescription was due to pain associated with sickle cell disease. Patient 5 weighed 181 pounds at her pre-op visit, and Dr. X at that time okayed the procedure. However, on the day of the procedure, patient 5's weight was 186 pounds. Patient 5 suffered necrotic full thickness burns across large areas of her abdomen and her flanks. Unlike patient 1's, patient 5's burns were full thickness. So that means basically just through all of the dermal layers.
As in through each layer of skin?
Yes.
Oh my goodness.
She was hospitalized for 17 days with infection, with just skin necrosis all over. She was debrided several times by plastic surgeons. She has visible scarring over large sections of her abdomen.
And that's the happy ending for patient 5.
She survived it.
Wow. So I feel like there are a lot of questions to ask. That is all 5 patients. And I feel like we need a break from that. Throughout the hearing process, I know that Dr. X testified that many of the consequences, including the deaths of the patients, were not her fault, which is preposterous to me. She claimed the blistering on patient 1's abdomen were caused by high-waisted garments for post-surgery. She said patient 2 denied having sleep apnea. She admitted her documentation could be better in certain places, but denied knowing about patient 5's sickle cell diagnosis, as you mentioned. Honestly, overall, it seemed like Dr. X didn't want to take responsibility of the consequences of her actions. And these outcomes were nothing less than tragic. Stay tuned to hear what happened to the provider after a short break.
The Medical Board creates rules that clarify and amplify provisions within Ohio law and govern practice for all its licensees. If you're curious to learn about the process to adopt new rules, visit med.ohio.gov, navigate to the Laws and Regulations tab at the top of the page, and click on the Rules section. There, you will find the board's rulemaking guide with a summary of each step.
Welcome back. When I first started sifting through this case, I just had no idea how serious the complications from Dr. X's procedures were. To many, if not all of the patients in this case had underlying or chronic health conditions, they absolutely made them bad candidates for elective surgeries. Is it normal for physicians to have an understanding of a patient's health issues before performing any kind of surgery?
Normal, yes. Expected, and in most cases required. It's required for a physician who's treating a patient on a non-emergent basis to have an understanding of the patient's history. That's what you should expect from your doctor, and that's definitely what the state expects from your doctor. When you go to a new physician, you fill out a bunch of forms, you check boxes.
Every time.
Yes. They may annoy you, but they give the doctor a background into your health, and not just the ones where you're checking boxes, but the forms you sign where you're giving the doctor permission to access your prior records. The doctor's supposed to access your prior records, so the doctor knows what he or she is looking at. Yeah, and that's true, like you said, for any surgeon and for any physician, right? But it's especially true. It's imperative when it comes to an elective cosmetic procedure, for the reasons that we've already talked about.
So after going through the accounts of these patient outcomes, what was the underlying basis of the board's concerns? And I'm calling this out specifically because I don't want it to be I want it to be very clear why the board cited her to begin with and why they decided to move forward. And not just because, well, it was just a single case of a sedation issue, or, we weren't too thrilled about like your bedside manner. Right. What was the underlying issue?
So the board's expert, going back to the board's expert opined that Dr. X's treatment of each of these patients fell below minimal standards. That means that, and also opined that Dr. X did not appropriately consider the patient histories, did not properly assess whether the patients were candidates for cosmetic procedures. With patients 1 and 5, this failure to properly evaluate their candidacy led to permanent scarring and hospital stays. For patients 2, 3, and 4, they died. They arrested either at the office or later on that evening, all 3 of them. They did not survive elective cosmetic procedures, at least in part due to Dr. X's failure to properly evaluate them as candidates for surgery in that office setting. So when most lay people hear about standard of care, as it relates to the practice of medicine, they're probably thinking we're talking about malpractice. No, malpractice is a legal determination that's made in civil court. It's usually in a dispute between one patient, and one or more care providers, and usually based on a poor medical outcome. Malpractice is most often due to a medical mistake caused by a practitioner's negligence. But our job is different than that. The board's determination that Dr. X practiced below minimal standards is separate. The minimal standard of care is the baseline expectation for how a physician should approach a patient, given the patient's history and the care that the patient is requesting or that the doctor determines is required. It's not merely negligence. Negligence is mistake. These aren't mistakes. The choices that she made in patient and treatment selection and the care during the treatment were outside of the bounds that a physician conforming to minimal standards of care would consider appropriate. Even if the best outcome happened in each of the cases, the care still would have been problematic due to the patient selection and treatment selection. And that's the board's interest is always moving forward and making sure that we safeguard the public.
The board reviewed the entire hearing record, revealing the details of this case. So all of the details plus more. Usually we're talking about hearing records, we're talking about hundreds, sometimes thousands of pages of documentation, medical records, pictures, all kinds of things, interviews. What was the final decision from the board after review of all of the evidence that was brought to them?
The board voted to permanently revoke Dr. X's license to practice medicine and surgery in the state of Ohio, and they fined her $3,500.
Permanent revocation. That's a familiar term now, hopefully, to our audience, because that's what happened in a previous case we talked through. But that basically is what we consider a death sentence in licensing. You're never going to be able to practice in Ohio again. We no longer trust that you have the ability to safely treat your patients. That's heavy, but again, considering all of the fallout from the care that Dr. X provided.
Yes, part not just because for all the reasons we stated, but it wasn't just the same mistake being made over. These were different patients in different circumstances with different procedures, but a pervasive issue with her care.
Yeah. So I have to ask the question then, what can we learn from a case like this? And by we, I mean anybody?
Well, if you wonder whether an aspect of your health history would be relevant to the care provider who's treating you, tell them what they don't know. Ask questions. Expect good answers. And even more so if you're ever considering cosmetic surgery. Find out where your procedure is going to take place. If you're getting liposuction combined with another procedure, like a facelift or a tummy tuck or a breast augmentation, that has to be in a hospital or an ambulatory surgery center. If a practitioner is telling you that they're doing it in their office setting, they're about to do something that's not only unlawful but unsafe. If the procedure involves sedation, ask whether an anesthesiologist will be on site. And sometimes there's a nurse anesthetist, and that's okay in certain settings. Your doctor should be able to tell you what those settings are and what they aren't. If you're thinking of getting cosmetic surgery, talk to your GP first. Your GP knows you better than the person you haven't seen yet that you want cosmetic surgery from. Find out if they think you're a good candidate. You may see commercials from nationwide cosmetic surgery centers advertising a cheap price and a quick recovery. Just do your homework. Find out what the background of any physician that's going to be treating you is. If they're trained in the procedure, where they're trained, ask them. If you ask them, are you trained in this? And they say yes, and you say, ask them how, right? And if they say, well, my residency wasn't, that's a good answer. They should be able to talk about their residency. That shouldn't bother them to do. If they mention the brand that you saw in the commercial as where their training came from, just, keep doing your homework. It's your body. You get one body, you get one life. Nobody's going to safeguard it more than you. Don't take it for granted.
I'm glad you mentioned the qualifications aspect, because that's something that board certification, I know in our last episode James Wakely talked about that a little bit. You can find out. He said you can ask the provider, are you board certified? What's your residency in? And we actually can look up providers on elicense.ohio.gov. I can put some details about that in the show notes, but elicense.ohio.gov, you can actually see if this physician is board certified and what they're board certified in. Because maybe if you see I can't say it. How do
Otolaryngologist.
Thank you. That's not quite the same thing, perhaps, if you're looking for a breast augmentation or a facelift or something like that. So I think that's an important resource. And I also know you mentioned discounts. One of the interesting facts to me in the R&R that was listed multiple times was the price the patients were paying for these services. And in the documentation, to show what these patients are being promised. You can pay this price. This is not the market rate, right? This is a great deal. And, we saw what happened as a result of maybe what seemed like a good deal financially. But like Tim said, you're putting your body on the line for someone maybe who's not properly trained. Sometimes even if they have the understanding, they may not have the intentionality or, quite honestly, the character to make sure that the proper precautions are taken. Because this can be sometimes about money, unfortunately, or this can be about getting as many surgeries done as possible. So I'm glad you brought that up.
Yeah, and it's ultimately, it's up to us to be our own best caretaker and to make sure that whoever we put trust in deserves that trust.
Okay.
Good practitioners will appreciate patients who take their health as seriously as someone who listens to a medical board podcast does. So ask questions. If somebody doesn't like you asking questions, find somebody else.
Tim, last question for you today. What do you find most rewarding in your work?
Well, I get to put most of my time into pursuing facts to find doctors or other practitioners who are not keeping their patients safe. If the board is pursuing an action, that means we've probably already encountered an outcome that is undesirable. That's unfortunate. Like in this case, we have 5 terrible patient outcomes. But I get to help afterward to try to safeguard that harm from being repeated. And in some special situations at the board, like today, I get to do a bit to safeguard that harm before it happens, just by helping educate. With a better educated public, we can help ensure better outcomes. When you go with a family member to an appointment, or you go yourself, remember to ask questions. Disclose everything you can remember.
Well, I agree with everything you just said, Tim. Our hope for today is that you've gained a basic understanding of what it means for a provider to meet the standard of care. If you're listening to this episode and you believe your provider's practice fell below that standard, please file a complaint today. You can do that on our website at med.ohio.gov. Like I said earlier, trust and confidence is essential to a provider-patient relationship, and it's important that Ohioans have access to safe, qualified practitioners. Until next time, thank you for listening. Thank you for listening to this episode of MedBoard Pulse from the State Medical Board. Special thanks to our guest, Tim Norris, for helping us understand the importance of the standard of care. Subscribe today to hear our episodes right away. For more information about the Medical Board, visit med.ohio.gov. You can also email questions or comments at communications@med.ohio.gov. And remember, the more you listen, the more you'll learn, the more you'll share.